I'll give it a couple more minutes before I start. Hello, Dr. Spillane.
Oh, hi, how's it going?
Good, how are you? Yeah.
Good. It's been a while since I've logged on to Journal Club in real time, so it's pretty exciting.
Well, I'm literally joining this and I've got like an hour to clean the house and then I head to the airport to go to Thailand. So it's
Oh,
a
yeah, I caught the tail end of
yeah.
that. It's exciting.
Yeah,
I
so
mean,
hopefully it won't take the full hour.
yeah, awesome. Enjoy.
Thanks. Yeah. How are you?
Yeah, not bad actually,
Okay.
and I'm not employed right now.
Oh, well, you're living the best life there.
Yeah, I have no job, so hence why I thought I'd watch Journal Club to stay
Yeah,
in the
that's
know. I'm moving hospitals actually.
that's right. I think I remember you telling me that. So
Yeah.
congratulations. That's
Oh, thank
exciting. Yeah.
you. Thank you.
Yeah.
Excited.
Have you got a bit of time before the new one?
I have a variable amount of time because I'm waiting for my green card work
Oh
permit to
yeah,
be
that's right.
approved before
Yeah.
I can start working. So it might be like another 2 weeks, but potentially like 4 months. So hopefully on the shorter end of that.
No, I'm like hopefully the 4 months. Like take a
Um,
holiday. Yeah.
I mean, I think a month off is good, but four
Yeah.
months is going to be a bit long.
You are living in LA, which is expensive.
In Orange County now, actually, we
Orange
just
County.
bought a
Sorry,
house.
sorry.
Yeah.
Yeah. Yeah, true, true. Yeah.
I
Got a
mean,
mortgage to
still
pay off now.
expensive.
Yeah.
Yeah. It's not a good time to be unemployed.
No. All right. Well, I might start, and it probably won't go for the full hour because this paper isn't exactly what I thought it was going to be when I picked the title. But this talk is going to be from a paper entitled Prevalence, Recurrence, Risk Factors, and Adverse Clinical Outcomes of Hyperkalemia in Maintenance Hemodialysis Patients. So this is a human study out of BMC Nephrology, which was published this year from the group in China. So a bit of a background, obviously, as we all know, hyperkalemia is a common electrolyte disturbance in chronic kidney disease patients. It frequently results in poor clinical outcomes in CKD patients in humans, and especially in people on maintenance hemodialysis regimes. And as serum potassium increases, the rate of major adverse cardiovascular events, or MACEs, hospitalization and death increases in people. But there's been no clear threshold of hyperkalemia at which these complications were expected to occur, and the relationship between the different levels of hyperkalemia and adverse clinical outcomes hasn't really been studied in detail. And the precise relationship between hyperkalemia and the clinical outcomes of patients on hemodialysis still needs further study. And so many human studies have suggested that the risk of hyperkalemia-related adverse events have been increased when pre-dialysis serum potassium levels were greater than 5.5 or greater than 6 millimole per liter. And so when we think about sort of a bit more of a background, this was a recent study 2021 looking at cardiovascular and renal outcomes associated with hyperkalemia in chronic kidney disease in people, and they found that overall hyperkalemic patients had higher risks of death, hospitalization for cardiac events, heart failure, and renal replacement therapy introduction than controls. What do we know about this in veterinary medicine? Well, there isn't really a lot. We all know that hyperkalemia is one of our main sort of initiators for hemodialysis, but there's not really sort of anything in the literature about sort of, prognostically sort of what that sort of means for our patients. And so, we often sort of expect these patients are going to be worse, but there really isn't anything. And so this was a paper back in 2022 looking at long-term outcomes of dogs recovering from AKI. And they didn't find a difference in long-term survival between dogs managed medically or using hemodialysis, which is interesting. So there's no sort of difference in long-term outcome, and obviously hyperkalemia being one of our main factors as to where we sort of initiate hemodialysis. And potassium wasn't mentioned in their multivariate analysis as, what sort of, had potentially sort of, increased odds ratio of death and things like that. There was another sort of, paper sort of about 10 years ago now looking at sort of clinical scoring outcomes in dogs with AKI managed by hemodialysis. And They didn't include hyperkalemia in any of the scoring systems because they sort of mentioned, well, once hemodialysis is initiated, dogs are unlikely to die from consequences of their hyperkalemia. And conversely, hyperkalemia is more likely to influence prognosis of dogs managed medically. And so it wasn't sort of included. So we don't really have any of these big studies in veterinary medicine either. So the aim of this human study was to investigate the prevalence, recurrence, and risk factors for hyperkalemia in patients undergoing maintenance hemodialysis. And then the sort of secondary outcomes were to explore the associations of different levels of hyperkalemia with adverse clinical outcomes. And then lastly, to determine whether there was a threshold at which potassium was associated with a marked increase in major adverse cardiac events and hospitalization. So this was a retrospective study based on, I think there was 3 or 4 dialysis centers based on Sun Yat-sen University in China. And the inclusion criteria was people needed to be receiving dialysis at least 3 times per week. They needed to be greater than 18 years of age, dialysis duration greater than 3 months with at least 1 recorded serum potassium measurement, and complete case information and patient cooperation. They were excluded if they had an estimated survival period of less than 1 year, planning to undergo kidney transplant within the next 6 months, if they had a severe infection or surgery in the past 6 months, with rickets or primary parathyroid disease affecting calcium and phosphorus metabolism, and patients with confirmed or suspected malignant tumors. And so demographic and clinical data, including age, sex, and comorbidities, were collected. And this was sort of over a 4-year period between January 2020 and March 2024. And during these human patients on maintenance dialysis, blood samples are regularly obtained at 3-month intervals at least, which I thought was quite interesting since we sort of do them, quite regularly. And hyperkalemia was sort of defined as sort of exceeding sort of 5.0 millimoles per liter. And then for univariate and multivariate statistical analysis, they aim to identify factors associated with hyperkalemia, and they use that cutoff of greater than or equal to 5. And they determine these major adverse cardiac events as either sort of hospitalization for unstable angina, non-fatal myocardial infarction, sustained ventricular arrhythmia, congestive heart failure, transient ischemic attack, or stroke. And so this is just the consort diagram of sort of, who were sort of included. So initially they sort of had 544 patients, about 45 were excluded because they had a history of kidney transplant or left the hemodialysis center, data was missing or some died. And then they sort of further then looked, they had to have at least 1 non-missing lab value after enrollment. So there was a total of 499 maintenance hemodialysis patients included in this study. And so in terms of the results, so they had a total of 319 males and 180 females with a mean age of 58 years. The median dialysis duration was 37 months, with a range between 15 months and 75 months. And the dialysate potassium-based prescription was set concentration of 2, that was their standard dialysis setting, no matter what. And interestingly, no patient was prescribed any other binding agents for long-term management of hyperkalemia during their entire 4-year study period. And so from these sort of 499 patients, 275 or 55% had hyperkalemia. And of that, about sort of half had a single episode of hyperkalemia and the other half had recurrent hyperkalemia. And when they referred to recurrent hyperkalemia, about half had sort of, 3 or more recurrences, or just under half, and then 57% had 2 recurrences of hyperkalemia. And then they looked at sort of what are some of the risk factors associated with hyperkalemia. And sort of the first one that they found was being male had a decreased risk of hyperkalemia compared to female. That's like the one time we benefited in one of these stats, I think, as males. If you had a higher KT over V, you had less likelihood of hyperkalemia, which makes sense. if your serum albumin was a little bit higher, and then obviously correlated with creatinine as well. And interestingly, PTH was higher in the hyperkalemic patients compared to those that did not have hyperkalemia. Looking at serum phosphorus, again, it kind of doesn't sort of seem too unexplanatory, but serum phosphorus was higher in those that had hyperkalemia compared to those that didn't, and the same with urea. And then the use of ACE inhibitors or ARBs, about sort of, 52% had sort of hyperkalemia if they used, an ACE inhibitor versus those that didn't have hyperkalemia, only sort of about 38% used an ACE inhibitor ARB. They then looked at multivariate logistic regression analysis of these risk factors, and they sort of found that looking at gender still had a p-value of less than 0.05, the use of ACE inhibitors and ARBs, dialysis duration, obviously in months, and so the longer they were being dialyzed for, the longer the increased risk of hyperkalemia, and KT over V as well. So the decreased KT over V had a higher risk of hyperkalemia. And then also creatinine as well, with a higher creatinine as well. They then looked at characteristics of these maintenance hemodialysis patients with a single hyperkalemic episode versus recurrent. And really sort of the things that sort of stood out with serum albumin was a little bit higher in those with recurrent hyperkalemia compared to the single. And serum phosphorus was higher in those that had recurrent hyperkalemia compared to those that had a single event of hyperkalemia. Looking at sort of, other things, weight growth percentage was a little bit higher in those that had recurrent hyperkalemia. And if we go back, sort of there was no real difference between the use of ACE inhibitors or ARB drugs, compared to single versus recurrent hyperkalemia. And so then they looked at multivariate logistical regression again after they sort of had that initial look, and really sort of serum albumin, serum phosphorus, and weight growth percentage as well. And then they looked at sort of, well, what would be the major adverse cardiac events and hospitalization rates in patients with different frequencies of hyperkalemia. And so we've got our normal potassium group, and so about 25% had an adverse cardiac event. Those that had hyperkalemia overall had about 35%, major adverse cardiac event. And then when broken down to a single hyperkalemic group versus recurrent, the single group were just sort of, a little bit higher than the normal potassium group, so 26%. But those that had recurrent hyperkalemia, sort of 43% had major adverse cardiac events. And this is pretty similar for hospitalization as well. But even those that had a single hyperkalemia event were much more sort of likely to be hospitalized compared to those in the normal potassium group. And then they sort of looked at, well, what would be the association between elevated serum levels of potassium and major adverse cardiac events and hospitalization in these maintenance hemodialysis patients. And so looking at a potassium greater than or equal to 5, the odds ratio of getting a major adverse cardiac event was 1.6, and then adjusted was 1.5. And they adjusted this based on age, dialysis duration, use of ARBs, and cardiac valve calcification. They also sort of adjusted for serum potassium relative to normal potassium in these maintenance hemodialysis patients as well. And so greater than 5 had an 1.5 odds ratio of having a major cardiac event and a 1.5 risk of hospitalization. Greater than or equal to 5.5, it was pretty similar, 1.59. Hospitalization was a little bit higher, odds ratio of 1.8. And then looking at greater than or equal to 6, had 1.8 odds ratio of a major adverse cardiac event versus an odds ratio of 2. for hospitalization. And sort of the odds ratios don't sort of cross, one, they're not sort of less than one, it's sort of with the 95% confidence interval, so they are significant. And so I thought this paper was going to be this big groundbreaking paper, and that was sort of the only bit of data that I sort of got from this paper. But there were some interesting things, obviously, not things that were sort of, that unexpected, but obviously maintenance hemodialysis patients have shorter dialysis histories exhibit a lower propensity for developing hyperkalemia, which I think makes sense. Hemodialysis patients with a lower KT over V are prone to hyperkalemia in this study. And the risk of hyperkalemia in patients treated with ACE inhibitors or ARBs was 3.79 times greater than patients not treated with these drugs. Hyperkalemia was independently correlated with a higher risk of major adverse cardiac events and hospitalization. And then looking at sort of, those different ranges of potassium, we could see that escalating serum potassium levels were associated with an augmented risk of major adverse cardiac events and hospitalization. Obviously, this paper had a few limitations. One has been a retrospective study. There wasn't huge amounts of data, as we sort of said. They were just made sure that they had to get blood work at least once every 3 months. And then, it's a little bit hard to glean sort of the temporal relationship between hyperkalemia and the outcome, right? So I guess when you're doing a cohort study, sort of examining exposure outcomes, sort of the exposure of hyperkalemia must precede the outcome, versus like in this study, there was no temporal sequence. And so, yes, some had major adverse, cardiac events and hospitalization, and they also had hyperkalemia, but it wasn't clear based on this study if the hyperkalemia came first. And so I guess that's sort of, the major limitation from this study. I guess I wanted to sort of open up to the group. Things I found interesting is that sort of, none of these human patients were on any, potassium binders, which I think sort of, it's interesting that they didn't add that on. And I find sort of now, at least sort of veterinary dialysis patients that really sort of, even sort of, we've got dogs walking in with potassiums of, 6, 7, 8 sometimes in between the dialysis sessions, and we really don't see sort of, a big sort of, increase in the major adverse cardiac events, at least that I've sort of seen. I don't know if you kind of agree with that statement, Mandy, or anyone else sort of on the chat. I think it's far more a human phenomenon, but I guess I wanted to see what people thought that are doing more dialysis than I am.
I feel like I agree. I think the dialysis patients that are hyperkalemic tend to be a little bit more chronic, and I think there's definitely a
Yeah.
difference between like chronic and acute hyperkalemia.
Yeah.
But I feel like Lokelma can be super helpful once they get like above 7 or like increasing the dialysis dose.
Yeah.
Yeah, so that's interesting. Like they didn't
Yeah.
comment on that in the paper. Super
Yeah. And
surprising.
obviously
What
we
was
do.
like the highest potassium like some of those patients had?
I think it was in sort of the sixes. It wasn't sort of anything
That's
above 7
crazy.
from memory. Yeah.
Yeah,
Um,
maybe that's why.
yeah.
I don't know.
Yeah, maybe that's why. So we've definitely had sort of ones walking around potassiums at 8 that are walking around the clinic as if nothing's wrong with them in our chronic dialysis patients, and you're like, you should you should scare me more than you do.
Do
Yeah.
you have a source for Lokelma that is a little bit more affordable? Just seems like it's really cost prohibitive for most of my patients.
I don't have a
Yeah, I
source.
don't. Yeah.
Yeah, we use
Uh,
just the 10-gram packets because for us, like when we looked at pharmacies, the 5 grams were just the same cost as the 10-gram packets. And then if the clients are smart enough, then we'll have them just purchase a gram scale and split it up into aliquots at our intended dose. Otherwise, we'll have them bring it in to us, and our pharmacists are kind enough that they will do it for them. But no, we're just using the trade name Lokelma, which we're probably still a couple years away before there's any generic formulations of it. Some people say that they can get patiromer cheaper, but I haven't found it to be cheaper, but it's one of those things that if you're prescribing it, which I don't feel like we prescribe all that commonly, like it might be worth comparing the prices of patiromer and Lokelma and just to see if for whatever reason there was a price drop in one of them. And I think they're about equally effective in people. So if you can get patiromer for a lot cheaper, then maybe do that. I know Sherry was using patiromer because it was a lot cheaper in Canada for her than using Lokelma. So it's another good option, just not necessarily cheaper. They're both expensive.
Yeah, I looked just like 2 weeks ago, and it was not any cheaper when I looked. But I appreciate that. Yeah, I'll every once in a while there's a case where I'm reaching for it, and it just seems so ridiculous in costs. But yeah, I don't remember if I looked at the 10 and the 5 gram packet, so I appreciate that.
Yeah, and I don't know if everyone uses like all the crazy weird discount things that are available online, but like, there's obviously GoodRx, and then there's
Yeah,
like
that's
Cost
where I
Plus
used.
Drugs, which is another one.
Which one is that?
It's like Cost Plus Drugs or something. It's like Mark Cuban's drug company.
Okay.
Oh,
Um,
really?
yeah.
Yeah.
What's it called? Yeah, Cost Plus Drugs. So that's another one that is like super cheap for stuff. Um, Let me just see if they have Lokelma. Um, at least not by the brand name that they have on it.
Yeah, and there were just recent changes I learned for some drugstores that they're now requiring an NPI to accept GoodRx coupons. So that
Yeah.
was another hiccup that was made it even more exciting.
Yeah. Yeah, it's frustrating because it works so much better obviously than sodium polystyrene sulfonate, which is cheap and causes tons of complications at the same
Yeah.
time. But it's almost malpractice to use sodium polystyrene sulfonate now when we have these other ones, except for the cost, But so that is a far cheaper option. You just have to be careful because it binds calcium, it binds magnesium as well too. So
Doesn't
you can
it
see
cause like
crazy.
necrosis too, or
Yeah, so
like weird GI?
yeah, so there are the reports of they thought it was likely due to the sorbitol in it, the colonic necrosis.
Yeah.
That wasn't completely worked out. And I think because it largely isn't used anymore, there's not a ton of people to go back and look at the data. But yes, that I don't believe it's considered to be a safe medication because that risk is not worked out and still potentially possible. But I think what else do we have for our patients? I've never seen colonic necrosis in anybody that I've used to treat it with, but
Okay.
that doesn't mean it's not like I've treated hundreds of patients or
Right. I would say,
100,
I mean, even in people,
right?
right?
So
It's probably
it's
like
probably
going in
smaller.
thousands.
Yeah, exactly.
So yeah, I mean,
I have caused constipation like with that plus,
Yeah,
but not no necrosis. Yeah.
yeah, for sure. For sure.
It always amazes me, these human studies, like how, I feel like we're so intricate when we dialyze a patient, but everyone seems to be, on the same prescription, not the best KTOVs, and it's just kind of almost this production line.
Yeah, no, it's so true. It's so true.
Yeah.
One thing I was curious about because I don't think that they said it, and maybe it's different in for these authors, right? Because they are from
China, yeah.
yeah, but at least in the US, if you're hyperkalemic, you're getting sent to the ER. Like
Yeah.
if you have a potassium of 6, you're getting sent to the ER for management. Like because there are
Yeah.
so many papers like this that do show an increased risk of adverse effects that you can have minimal hyperkalemia and then you're going to go to the ER and probably just get like put on fluids and have it diluted out and then you're going to go home and be told to follow up with your nephrologist. So the
Yeah.
major adverse cardiac episodes is certainly I think something that's very interesting to look at. But when you look at the rates of hospitalization and the risks for hospitalization with hyperkalemia, what I wasn't sure of, and maybe I just missed it, but if they were hospitalized because of the hyperkalemia itself, well, then of course, the higher the potassium is going to be, the more hospitalizations you're going to see. And clearly there are other reasons for hospitalization, but I wasn't sure if they had separated
Yeah,
that
they
separate.
didn't separate it out, and
Yeah.
they also, yeah, they didn't separate that out. They didn't separate any temporal association either. So they're like, these ones are hospitalized, but they didn't really say for what. You know, they had in their sort of, description about what the major adverse cardiac events were, but they didn't ever mention sort of what they were hospitalized for. And so
Yeah.
that, I think, was another bit of a letdown.
Yeah. And I don't know if it's the same in China, but certainly in the US, like that's just common practice for people. You know, if you
Yeah.
have like routine blood work and your potassium comes back and it's like 5.8 and you're healthy, and they're like, oh, go back to LabCorp and get it rechecked, as soon as possible. But if you have a patient with all these risk factors or an underlying disease, then that's when they're going to say, like, oh, your potassium is 6, so you got to go to the ER. And
Yeah.
if you haven't been on it, they're going to load you with glaucoma and stuff like that at that point. But so that, the MACE risk factors I thought was certainly more believable, but I don't know to what extent the
No,
hospitalization would be
neither. Yeah.
like a
Yeah, and
self-corrected finding.
exactly, and because it's retrospective, they're just like, yeah, I think we couldn't really
Right.
determine. I don't know what your thoughts are, JD, with chronic hyperkalemia in our veterinary patients. As sort of Mandy and I was saying, like, I don't feel like they experience that much cardiac. Like, obviously there's changes to ECG and other stuff, but like I haven't sort of found in the patients that I've chronically dialyzed that that's the reason they get worse or euthanized. It's usually from something else.
I agree. I agree 100%. And I think we're so used to it. And the bigger problem probably in the human side is, okay, recognizing there's all this data. If your K is higher than 6, you have this increased risk for death. And if someone doesn't send that person for care and have that rare complication, then that physician is likely going to be sued. So I think
Yeah,
that's probably a big part of it, where for us, number one, we don't tend to see those complications very commonly. We don't have the litigious aspect as well, too. So instead, we see dogs walking around all the time with potassiums of like 7.5, and they're
yeah,
happy. And as Mandy said, like when it's chronic, like they don't really seem to care.
no, yeah,
And I'm pretty happy pushing our patients with ACE inhibitor. Well, I can't tell you the last time I used an ACE inhibitor, but like with an ARB,
yeah,
if we get their potassium, like if their potassium isn't reaches the high 6s, then I'm probably at that point not going to push the dose anymore. But if their potassium is still like 6.1, I'll probably still push their telmisartan dose a little bit, but I
yeah,
tend not to push it up into the 7s because I worry if they have any complication that causes it to jump up another point, well, then maybe that's when at some point they'll have a problem. But yeah, our
yeah,
patients tolerate it really well.
yeah, 100%.
So I think we do tolerate it a whole lot more than people. Um, I think another thing they didn't really mention, but most people that are getting chronic dialysis, they're oliguric, if not anuric. And so you
Yeah,
can imagine, like, the higher their potassium is, the more likely those patients are to be anuric, the more likely they are to have other complications to go along with that too. So, sure, the multivariate analysis did pan out, but was
Well,
potassium driving it, or are these patients just sicker and they also have worse potassiums going along with a worse disease state?
yeah,
yeah, well, and look
100%.
at the connection, right, between cardiovascular disease and CKD in people, right? Like it's a totally different entity than what we see.
Oh yeah, I mean that's what they die of, right? They don't
Right,
die of kidney
exactly,
disease.
exactly. So it's not really all that shocking to me that,
Right.
that the ones that had worse CKD and like you said were probably all uric and at least all uric.
Sure. Yeah.
And have GFR somewhere between 5 and 10, something like that. I mean, it's not
Or
incredibly
zero, right? Because
or
if you're
zero.
in
Yeah,
Europe, your
exactly.
GFR is zero, right? And
Right.
and so many people, I don't know if anyone has friends or family that have had chronic dialysis, but like they don't urinate anymore. Or it's a rare event if they have enough like bladder sweat to accumulate, but it usually doesn't increase in volume enough that they
Yeah. They
ever feel
don't
the need
urinate
for
much.
it.
Yeah. So
Yeah.
so I mean just it just seems like, I don't, predictable, I guess is the word I'm looking for, that the
Exactly.
sickest ones
Is it a big
died.
shocker? Right. Not really.
Yeah, exactly. Yeah.
Right. The worse their potassium is,
There
the
wasn't
worse
I
their
thought there was going to be some nice like light bulb moments from this paper, and it was just like, okay, these are all kind of things I expected. I'm sorry, it's a bit of a boring paper.
Well,
The
the
thing
other
that,
thing
yeah,
about it too is like you look at their, look at their KT over V doses that they get, and
yeah,
1.4 to 1.3, most of our
embarrassing.
patients we're treating far higher of a
Yeah,
dose of dialysis than what people
yeah.
get.
I'd
You know,
be embarrassed if I got that.
right, because that's like a 70% URR, right? And so
Yeah,
if we're treating an outpatient with 70% URR, we're probably a bit bummed overall,
yeah,
unless we see that the catheter sucks and that's all we can do, or they're a huge dog and we're trying to treat them, and that we have two dialyzers and that's all we can do. But these people are getting treated for like 3 hours with a
yeah,
70% URR. We're treating our patients that are half or a quarter of the size for 4 to 5 hours with a KT over V of 2, 2.5, 3.
yeah,
Um, and you wonder, like, are we doing too much sometimes? Are we over dialyzing? Could that be a problem? And not that we know in our patients, but it's also, we haven't looked at it, nor are we adequately powered to look at it.
yeah. I know Dr. Calois has said that it's like some of these ones that we over dialyze them, and I guess yeah, how do we actually look at that?
Well, you just wonder the unintended things. Larry had that paper that was like decades ago, but showed even after like 2 weeks of dialysis that dogs are getting amino acid deficiencies because you're
Yeah,
removing them. So you think about cranking up the dialysis, like great, maybe we're getting more uremic toxins, but maybe we're getting some of these molecules that we're not really evaluating very well. Like how many times you run an amino acid panel on a patient, like
yeah,
that you're dialyzing. Like we probably should be, because we don't know when we need to supplement. And those patients probably shouldn't even be on a kidney diet, right? Because they're burning calories. A person getting dialyzed burns as many calories as if they run a half marathon, just sitting there watching
yeah,
Netflix on the chair, right? So our patients are having calorie loss or having nutrient loss. They probably need to be on higher protein, higher energy dense diets, and we just don't have the first clue on how to prescribe their nutrition
yeah.
at all.
Yeah, I
So
think that's a great point,
maybe we could treat
Katie.
them too much. Yeah.
I just happened to be looking up today for something completely unrelated, but there is a paper in, I can't remember what, a more obscure journal about the metabolomics. It was from a couple of years ago of CKD dogs with and without a renal diet, and it looked at several several serum metabolomic things, and it was kind of interesting. But I wonder if now that metabolomics are much more available, if that would be something that could potentially help guide that question, and look at, you know, what what are they missing? Would super supplementation be helpful with some of these amino acid profiles? Um, and I think both calories and probably type of amino acid. And then also, we know about a lot of the vitamins, particularly the water soluble, but as they are catabolizing fat, I don't know what that's going to do to their fat soluble stores over time too. So
Yeah.
a lot to think about.
Yeah. And then it becomes like there's so many things you could test for, right? And you're like, okay, we just spent an extra $1,000 this week because we did vitamin levels, we did amino acid levels. We were checking all these things, which we should, but then
Where's the money left to treat the dog?
yeah, exactly. We all know how it is. Like at some point, it's just you're going down to twice a week to save the money. You're skipping
Mhm.
your post-treatment labs because
Yeah.
you're
What is it going
saving
to
the
change right
money,
now?
right? Like so it becomes a point where like I really want to find this out. I don't know if it's going to change anything, maybe, but it's not like those tests are cheap. So we
Well, but maybe that doesn't have to happen as a step one, right? With the client-owned dog, right? Maybe that's a pilot study where you look at a couple, a handful of dogs and get a grant from somebody, Morris or something, and
Yeah.
you look at 5 to 10 dogs, and you see if there are commonalities, and say, okay, we're gonna make at least a preliminary presumption that this is a typical response to dialysis, pre and post, and then treat those animals accordingly and see if there are differences. I mean, I think you could do a pilot study to be able to better determine this before it becomes individualized medicine. That's
Yeah,
going to cost each individual patient $3,000 to, create a nutrition plan for.
for sure, for sure. Because I think at least, from the little data that we have, the differences are big enough that I think a small sample size, you're likely going to be able to see something. It'll show, it'll come up. You probably don't need 50 dogs in order to look at the differences, because these differences are pretty significant. Like they're, methionine deficient versus normal.
Yeah.
It's not like,
Yeah.
oh, their methionines 310 versus 380. It's like, no, it's 100 versus 380. So
Yeah.
small groups might be able to do it. And certainly, within the realm of what we could do with a small grant.
Mm-hmm.
Awesome. And then I guess the last thing that maybe threw me a little bit is that I guess the time they're on dialysis was longer than I expected. Obviously in people it is, waiting, prior to waiting for a transplant. But maybe I'm living a naive life here in Australia, but I was like, oh yeah, it's probably less than a year or something like that. But this was
Wow.
obviously, a lot longer.
Is that the average time to transplant for people in Australia?
That's what I kind of assumed, but maybe.
Wow. Wow.
Yeah. Yeah.
Yeah, I mean, yeah, there's so many different problems that, people, and who knows what the system is in China, right? I have
Yeah,
no
exactly.
familiarity with that.
No.
But in people, some of these could have been previously transplanted and that failed, and now they're back to getting dialysis or
Yeah,
they're
no, these were all naive. That they couldn't have had a transplant.
oh, okay.
Yeah.
Um,
Yeah.
yeah, but plenty of risks that put them out of the
Yeah.
the recipient pool, and then just not resources, right? Like they're just
Yeah, exactly.
not enough people.
We're
Yeah.
big organ donors here in Australia, so I feel
Good for
like.
you guys.
Don't
Love
you
that.
think, Mandy? I feel like it's on our license. Every time we renew our license, we have to say what we want to donate, and I feel like it's a big cultural thing.
Is it? I don't know.
I feel like it is. Maybe
I don't
amongst
remember
mine.
it. No, because when I moved to the US in 2019, I thought it was weird. It was on the US license, the organ donor thing. I don't remember it being on mine. Maybe it's a Queensland thing, like New South
Maybe, yes.
Wales. Let's have it on the license.
I like that.
And
Dennis was very confident that Australia was like, yeah, we're really good, and Mandy's
yeah,
like,
we're really good.
oh, not any of that actually.
Probably, I don't know. I think we're probably
That's
fine
it.
and nice. I don't know. I'm a bit out of touch with how it works over there.
And then am I misquoting you, JD, when I think you said a few years ago, or that you asked a lot of human nephrologists what type of hemodialysis they would want, and the majority of them said peritoneal. Is that correct?
Close. 100% of them said peritoneal.
Yeah.
Yeah. So it was in
Yeah.
nephrology grand rounds at University of Wisconsin's Human Hospital. So it was all their nephrologists, transplant nephrologists, nurse practitioners, fellows, and everybody. So yeah, in-center HD, at home HD, or doing PD, and they all said PD. Yeah.
Interesting.
Yeah, which just blew my mind.
Yeah.
Come on. I thought,
Just more convenient for them.
yeah, I think so. I think that's really what it comes down to. I think it's lifestyle and in not, it's easier to take your fluids and your cycler and travel with it than travel with your dialysis machine or find a dialysis center. And yeah, outcomes are fairly similar between the groups. So yeah, I was shocked.
Yeah. Yeah.
I was about to raise my hand for at home hemo, being like, yeah, I'm gonna just do it myself. I don't know anything about dialysis yet, but I'm gonna do it. And no one did. And I was like, oops, I'm gonna keep my hand
Yeah.
down.
I did have a patient when I was at Davis, and the both owners were, this is a Sharpei that was getting chronic dialysis, and both owners were MDs, and they're like, can we do, at-home dialysis with her? And obviously we said no, but it was just brought up a thought, they were just like, well, we think we'd be able to do it. I was like, I don't think you'd be able to do it.
Right.
Yeah. So maybe the right people one day.
Well, Larry always says he's like, I that's the vision, to be able to train people to do it at home. And I've always thought, you are crazy, Larry.
Yeah.
Clients can't even do E-tube feedings. You think they're gonna die?
That's the vision.
Yeah.
The vision
Look,
for what?
I don't know. I think he like a more sustainable chronic dialysis population, I think.
Yeah. Look, he was the one that said no to these clients, and they did struggle as both human MDs to do the O2 feeding, so it's fine.
Yeah, exactly. You're like, there you go. There's your test. Can you feed your dog enough? Okay, you can't dialyze enough.
Oh, good. Well, thanks everyone for a good discussion. It was a relatively quick and simple paper, no big light bulb moments, but I think kind of just a good sort of, refresher of what's out there in the human literature.
Yeah. Well, thanks, Dennis. This is great. I always love to pull the papers from outside of our world just to allow us to kind
Yeah,
of
me too. Yeah.
regroup and make sure we're not missing something obvious, or just to compare everything. So that was
Yeah.
it was a good paper to, reflect on and compare to see what we do.
Yeah, exactly. All right, guys. Well, I've got to pack and I've got to go to the airport for a little vacation in Thailand. So, which life is very hard. So, enjoy the rest of your
Dennis.
Friday evening. Yeah.
Yeah.
All right.
Yeah.
Okay.
Well, have fun.
Thank you.
None of us are jealous. That sounds terrible.
All right. Take care, everyone.
Thanks,
Yeah.
Dennis.
All
See you
right.
guys later. Bye.
Bye.